welcome to Public Health Live, the third Thursday breakfast broadcast. I'm Rachel Breitster, and I'll be your moderator today. Before we get started, I would like to ask that you please fill out your online evaluations at the close of today's program. Continuing education credits are available after you complete our short post-test, and your feedback is helpful in the development of future programs. We encourage you to let us know what topics are of interest to you and how we can best meet your needs. As for today's program, we will be taking your questions throughout the hour by phone or email. You can call us at any time on our toll-free number, which is 1-800-452-0662, or you can email us at any time throughout the hour at phlive.ny@gmail.com. Today's topic is Public Health Ethics, a closer look at current issues. Our speaker today is Dr. Bruce White, the director of the Alden March Bioethics Institute at the Albany Medical Center. Dr. White, thank you so much for being here with us today. We're so excited to have you here.
Rachel, thank you very much for having me.
Sure. So, as we've talked earlier, ethics is a really large and complex issue. So in order to start honing in on the topic, can you talk about what are the objectives that you hope to accomplish today during our hour together?
Well, just a few things before we start. I really appreciate David Hoffman from the State Department of Health getting us together. And it's that networking that's really critical to what we do in ethics and in ethics education at the Alden March Bioethics Institute. So thanks again for having me.
Sure.
Let's start with some definitions. And I think that we have some slides that maybe illustrate these a little bit later on. But ethics is really about making decisions where we can all live better lives. We want life to flourish to the extent that it possibly can. And we think that making better decisions rather than worse decisions will make that possible, will make that happen. So a little bit about definitions, and then we want to focus on some current issues, really from the newspaper. In fact, I think if we had taken today's newspaper, or really yesterday's newspaper that talks about HPV vaccine, that would have been a perfect topic for today as well. So what we're going to be talking about are things that are in the news that really illustrate how good ethical decision making impacts people's lives for the better rather than for the worse.
So it's certainly, when you look at it in that big context and think about the things that are in the news, this is a big topic. So why don't we start with the word ethics, which in and of itself is a pretty big word. It's kind of a loaded word. So would you give us a breakdown of what we mean when we're talking about ethics?
Well, if we start with the root word from the Greek, ethikos, it means character. When Aristotle and the Greek philosophers first started writing about good character, they were really thinking about virtues. What makes a good person a good person? Thinking that if good people were making decisions, that they would be better decisions rather than worse decisions. Morality is a similar word. It comes from the Roman moralis, the Latin moralis, and it means custom. And what we would like for people to do is to customarily make better decisions rather than worse decisions. But it's really about the quality of life, that we have, and about the decisions that we make in everyday life.
Okay. Now, you have a quote that you shared with me from William Roberts' book, and I found it a very interesting quote, and I'm wondering if you would speak a little bit about that and the impact it has on ethics and what you're going to be talking about today.
I think if we can bring that slide up, it would be really good at this point, because it talks about everyday life. To live is to act is to choose, and to choose is to evaluate. We talk about values and ethics, and every single decision that we make, we really evaluate the principles or the goals of our life, in making those decisions. So this brings it down to earth. Every single decision that we make has an ethical component.
Sure.
But to live is to act is to choose, and to choose is to evaluate.
So all of us, this broadcast is about public health ethics, but all of us every day are involved in these different ethical decisions. Now, one of the things that we were going to talk about and we're going to look at is some of the differences in terms of, from a public health standpoint or from a clinical standpoint, what are the different priorities, who are the stakeholders, who's invested.
Yes.
So can you talk to us about that? I know we have a really helpful image that will illustrate it, but if you would talk about that, I think it would be great.
Well, the ethics or the applied ethics fields that we wanted to kind of compare and contrast today were professional ethics, research ethics, clinical ethics, and then public health ethics. And it really is bringing the sphere either closer or making it much wider. And starting with professional ethics, that's really a good place to start, because when people think of ethics, they think of how professionals should act. Almost every profession has a code of ethics. In fact, we're going to be talking about the American Public Health Association's Code of Ethics and looking at guidelines a little bit later. But in public health ethics, the stakeholders, are the public itself. But professional ethics is really designed for the professionals to help them make better decisions. Research ethics deals with human research subjects. And I've selected 4 topics today that all of them are dealing with drugs, which is a topic that's very dear to my heart. But it also shows how we regulate drugs and how we investigate drugs. I think when you and I talked earlier, there was a recent New York Times report about an experiment regarding a new drug that was being used in Fragile X children,
yes,
in autistic children. The mom who was being interviewed, for the story by Andrew Pollack, was very concerned because it looked as if the study was going to be closed, and her child, who had been benefiting, from participating in the study, was no longer going to have access to that drug. And that's because the mom, unfortunately, was confused about treatment and research.
Right.
And the research project was designed specifically to determine whether or not it was a safe product. It really wasn't designed for treatment. Well, we hope that it eventually become something that would be available for treatment, but in this particular instance, it was really more for safety.
Right.
And people are confused. The third category that we selected was clinical ethics. Clinical ethics is what we do every day. In fact, we've had 3 consults this week at the hospital, specifically on trying to help families, oftentimes when patients lack decision-making capacity, make better decisions rather than worse decisions. But it's focused on the physician-patient relationship, a very intimate, and like every field of ethics that we're talking about, it's trust. But this is really more of an intimate trust that we're going to find with public health ethics. And then the last one is public health ethics. And the stakeholders here are the community. And again, in every single instance that we're going to discuss today, it's, in a nutshell, how much liberty do we take away or limit to the individual in order to maximize benefit for the community? So we as a community, where life can flourish. Make sense?
Yeah, no, that makes perfect sense. And while it makes sense, that's such a complex issue, because how do we ever get straight answers to those questions? And I think, as you're going to explain throughout the day, we'll have to look a case-by-case scenario. Now, having looked at that chart and seen a little bit of the research ethics, the clinical ethics, can you talk to us more specifically now about public health ethics and how we would actually define what we mean when we say public health ethics?
And I think we have a quote from Powers and Faden that really, in fact, just reading it, public health ethics involves a systematic process to clarify, prioritize, and justify possible courses of public health action based on ethical principles, values, beliefs, the stakeholders, and the scientific and other information that's available. Let me take just a moment and talk about those principles, because that's really important to everything that we're going to be discussing today. So the 4 principles of medical ethics or healthcare ethics: beneficence, non-maleficence, autonomy, and justice. Beneficence, from the Latin word bene. We want to do good. We want to try to maximize good to the extent that we can. But with drugs and other decisions in the public health arena, oftentimes we can't do good while at the same time not risk harm. So non-maleficence, avoiding harm. How to do good and avoid harm is really what ethics is much about. Autonomy, from 2 Greek words, auto nomos, self-law. Each of us should be a self-law to ourselves to the degree possible. We want to allow everyone to live their life in freedom and liberty, make their own choices, and maximize, their potential and allow a life to flourish. But also at the same time, we want to be, in fact, if you look at the Declaration of Independence, all men are created equal. The implication is that all men. So my liberty is really no greater than your liberty. So we've got to find some way of kind of living in a community, and justice is about fairness, equality, appropriate allocation of resources based on what's available. So again, autonomy and justice, they're juxtaposed, just as we're talking about beneficence and non-maleficence. And that's what public health ethics is all about. How much liberty do we take or deprive the individual in order to maximize benefit to the community?
Which certainly seems like a complex question to ask. Now, I understand that public health ethics can be defined in terms of a field of study and a field of practice. Can you talk about that a little bit?
Well, we often think of art and science. Even teachers, think about art and science. And when we think about science, we're thinking about theory. How we learn how to do things. But in doing what we've learned, we often find that it needs to be nuanced, and that's the art. So in philosophy, there's the theory that we need to deal with, which are the principles, beneficence, non-maleficence, autonomy, and justice. And then there's the application. How do you apply it at the bedside? And I love principles. They're really very helpful.
Sure.
But in each instance, in each case that we're going to be talking about today, we really aren't going to know from the principles themselves what actions or decisions we should make.
Absolutely.
And that's ethics.
Okay. Now, are there different viewpoints regarding the role of ethics in public health? I mean, certainly, it seems like there could be room for different interpretation or different perspectives on how do we weigh these juxtaposed ideas, such as beneficence and non-maleficence.
And if you look back at the Powers Fade and definition, it talks about prioritization. It's like you've come to a fork in the road, and you've got to take one path versus the other. You're trying to decide which option is the best. And you look at all of what you know about this path versus the other path in order to elect one course over the other. HPV vaccine is a really good example. HPV, in fact, it might be good to share a little bit about the story. We've made HPV vaccine available to young women. There haven't been that many young women that have actually received the vaccine. I mean, depending upon the area in which you live, I think the report that I read was about 30–35%, which is not inconsistent with voluntary immunization rates in the flu when we talk about that a little bit later. All right. However, the number of HPV infections that have been identified in these young women have dropped by 56%.
Wow.
So the vaccine hasn't been available that long. It's been entirely voluntary, but the rate of infection has really dropped dramatically, and that is so beneficial, to everybody. It probably is the benefit a consequence of herd immunity, in the fact that if we keep the transmission rate between individuals down, that eventually collectively help the community. Regardless, it's just been. Think of how, to go through life with less of a fear for cervical cancer than you would, than you would otherwise. What a wonderful benefit. And for generation after generation. If we can interrupt the spread of the disease, we can decrease the rate of cancer, and children's children, will benefit from that.
Sure.
All right.
Thank you for sharing that example. Now, one of the things we talked about a little bit earlier and you referenced was that every profession has a code of ethics that guides the actions that they take in that field, and public health is no exception. And so the American Public Health Association, as I understand it, has a code of ethics, and I'm wondering if you would just share a little bit about that and the various principles that they've laid out.
Well, I think if we pull the slides up now that the audience can see those, we can just list them. Again, every profession has a code of ethics. It's not an exhaustive list. It's really more a set of aspirations. Some are more legalistic than others. But again, public health is the individual versus the community. And I hate to, it almost like it's a conflict. But in ethics, what we're really talking about is a dilemma that forces us to choose between values. And in this Code of Ethics from the American Public Health Association, it's a guide to help those people that are in the field, those public health care professionals, and make better decisions rather than worse decisions. I think if we look at the guidelines now, we can just kind of list them and just go through them very, very quickly.
Sure.
All right. But the goal of public health is to address the causes of disease, just like with the cervical cancer or HPV, but also address what the requirements are for good health rather than bad health. We're dealing with that with obesity.
Sure.
And in fact, this only today, today's the 20th, only today there's a report in New England Journal of Medicine about exactly what we're talking about, the influence of the state versus others when it comes to good health. Wearing seat belts, wearing helmets, all of those are really good examples of taking individuals' liberty in order to maximize benefit to the community. And that's number 2, achieve community health while respecting individual rights. I think we have a few more of these. Yeah. Policies, programs, priorities are developed and evaluated with input from community members. The stakeholders are the people who live in this particular area, in this state, in this nation, and they have a say in deciding what our public health priorities should be. And public health care professionals should advocate and work for empowering disenfranchised, vulnerable populations so they have greater access, to health care.
Sure.
All right. Public health professionals should seek information to implement policies and programs. We want to use evidence-based principles, and we'll talk about that today in the various illustrations of the cases that we have. And we want to, as public health professionals, provide communities with information and obtain consent for, their implementation. Act in a timely manner with resources and the mandate as given by the public. Usually that's a matter of funding from the state legislature. And we want to incorporate a variety of approaches. It respects the fact that one way doesn't always work, and we need to be trying multiple ways. Implement programs and policies in a manner that enhances the environment. We want to be green communities to the extent that we possibly can, and we want to protect confidential information. I think every single professional code of ethics would probably have that included as an element. And the last 2, ensure professional competence of employees. If we're the public, the stakeholders expect a degree of confidence, and we want to assure that through programs that we have in place. And then lastly, we want to be collaborative. We want to build trust, effective relationships with others in the community, because it really is, it takes a village.
So some of this, there's 12, obviously they're well articulated, well thought out, but it almost seems like common sense. What we're talking about is trying to maximize the public good, do the least harm, and do that while getting input from the people that are going to be affected, and do it in a way that's professional and maintaining respect and confidentiality.
Fortunately or unfortunately, almost every code of ethics reads in exactly the same way. The lawyers, through their models, professional responsibility, are a little bit more legalistic, and they deal with individual specific cases. But again, you can see these are very broad. How do you apply them? So we have the art, that's got to be coupled with the science in order to make better decisions rather than worse decisions. And I think that we'll see that in each of these cases that we discussed today.
Absolutely. Now, those guidelines that you just reviewed are for public health. Are there vast differences, and I know you touched on this a little bit earlier when we looked at that chart, but between ethics as they relate to public health versus clinical health? What would you say are the main differences between the two?
If we were to go back to that chart, I think that there's unique circumstances that need to be carefully articulated for each one of those. The physician-patient relationship in clinical ethics is so different, even though it's only slightly different in some degrees, from the researcher and the subject, that you really need to have different, you need to place emphasis on different principles. I hate to remind people of the Tuskegee experiment. This is the one that was publicized early in the 1970s. But it's almost like the public health officials who were collecting information about the natural course of syphilis forgot about the need to care for individual patients. So it was almost like they placed, you know, they prioritized obtaining research data over making important decisions, careful treatment decisions for the patient. And sometimes it means we shouldn't be doing this research. We should be treating the patient rather than participating in research projects. When that becomes obvious, the most important thing to do is to stop the research and to treat the patients. Now, and again, that's different. One would think that everybody is trying to help the patient. But you can see that in that particular instance, the public health physicians were thinking, well, I'm going to collect this data that's going to be more important with the community rather than this one individual. And that's where ancient philosophy, or not really ancient philosophy, Kant, said that, Immanuel Kant, a German philosopher, said we should never use people as a means to an end. They're always important as an end to themselves. And what those public health researchers in the Tuskegee Institute or the Tuskegee experiment were doing, were using people as a means to an end, and we shouldn't do that.
Absolutely. And it's interesting because the things that we're going to be talking about, the issues we're going to be looking at today, one of the things you and I had talked about is when we're making these ethical decisions, the way we view them today might not be how they're viewed a year from now, 10 years from now, and so we can look back at that, and it's, you know, like you said, it's hard to even bring it up and to remind people, and hopefully in the issues we're going to discuss today, we're making decisions that come a year from now, come 10 years from now, we can look back and feel comfortable with the decisions we've made. So let's start talking about the representative public health issues that you're going to be discussing with us today.
Well, again, all of them deal with drugs. I'm a pharmacist. I have a deep interest, you know, in trying to help people deal with drugs and drug therapy differently, you know, based on these ethical principles that we're going to be discussing. But the first one that we're going to be discussing is mandatory immunizations.
Okay.
Should we make people get shots in order to benefit the public? The second one that we're going to be talking about is the availability of emergency contraceptives. The third one is the availability of medical marijuana. And then the last one is physician-assisted suicide. Now, I want you to help me here because I want to be cautious. I want to present balanced arguments. And my goal is that if I have a personal opinion, no one really knows what it is.
Sure.
You know, after we finish the conversation. I may be passionate in arguing one position versus another, but I want to be equally passionate because people's values are embedded in the arguments that we're going to be discussing and be making today, and I don't want to appear disrespectful of those arguments in any way. But I am going to, and we're going to illustrate with each of these cases, oftentimes a law is going to settle the issue. And it's not that the ethics question has been resolved by a legal answer. It's just that in our society, when we're trying to balance individual liberty with community safeguards and community rights and benefits, it's the law that really kind of settles this in a way that we can live with it. So the ethical question is, what should we do? The legal question is more like, what can we do? What do we have to do? Okay. And oftentimes those are the same, but you'll see in these cases that we'll discuss today, they still are different.
Sure.
All right.
Okay, so let's start by talking, the first one that you mentioned is that mandating flu vaccines. So give us a little bit of history on vaccines, the flu vaccine and how it's being used, just to frame the discussion we're going to have.
Well, other people may answer this question differently than me, but if someone were to ask me, how has public health really helped, benefited the public, especially here in America? The two things that I would say is that it's brought us clean water, safe and clean water, and the second, it's made vaccinations available to everyone. having grown up in a small town in Tennessee where there were polio cases. In fact, our public health doctor in my hometown, Elizabethton, Tennessee, was himself a victim of polio. So he was paralyzed because he had polio. So having polio vaccine available, look, we've almost eradicated, that disease, and it's been so marvelous. The flu. The flu is a little bit different. It's communicable. Each year in America, we have about 35,000 people who die every year from the flu. The people that are the victims are most often very, very young or very, very old. They usually die of the complications of developing pneumonia. But having lived through the H1N1 scare in 2009, and then having read John Barry's book, The Great Influenza, H1N1 scares the living daylights out of me. I mean, to think, and if you read John Barry's book, it killed more people than the plague, in the Middle Ages, a greater percentage. It reached even to the Alaskan villages and devastated populations there. One of the interesting things about when you read the book is that the author theorized with experts that it developed in Haskell County, Kansas, all right, where there was a mixture of swine, hogs, and chickens because of the farming community, and it was just the right mix for the mutation, of the virus. So H1N1 is going to kill people. So can we reduce the number of fatalities, by asking people to get their flu vaccine? More importantly, can we ask healthcare workers, to be immunized, so they can reduce the transmission of disease and, to be honest, from an altruistic point of view, be more readily available, to take care of other people who are sick and decrease the transmission to their families, because you've got nurses, pharmacists, physicians that are going to be working in the hospital that are going to be coming into contact with other people that have H1N1, and if they work, they're going to be going home. So can we use immunizations? And we know from data from Japan that the more people who take the flu vaccine, just like the more people who take HPV vaccine earlier, it reduces the transmission of the disease. But healthcare workers, for various reasons, have been reluctant, to get the vaccine. And again, it's having to make someone do something that they really don't want to do. So there's some people who feel like that if I take the flu vaccine, I'm going to catch the flu. That hasn't been proven in the literature, but it's still a myth that's been so difficult to dispel. So in Pennsylvania, the hospital of the University of Pennsylvania a couple of years ago required employees of the hospital to get flu vaccines, and they made it a condition of employment. So the University of Hospital is a private institution. In fact, hospitals do this all of the time when it comes to evaluating the availability of antibodies in their body to fight certain infections. When I move from hospital to hospital, people recheck me to see whether or not I've been exposed to chicken pox or been exposed to German measles. And if my antibody titers aren't high enough, they're going to ask me to get another MMR. So we have a history of making employees do things like that to reduce the transmission of disease, but with the flu vaccine, it's been more of a struggle. In fact, I think one of the slides reminded the audience that in 2009, the current Commissioner of Health here in New York issued an emergency regulation that would require hospital employees to get the flu vaccine. That was challenged. The suit was eventually the lawsuit was eventually withdrawn. I'm so grateful that we almost broke the bank, reached a breaking point, but somehow or another it was diverted. But getting people to making people to take the flu vaccine, I think, would have really helped.
So let's talk about it from an ethical standpoint. And I mean, I think all of these are ethical issues when we're talking about, do we force someone to get a vaccine if we think it's going to protect the community as a whole, if we think it's going to protect their patients or make them more available to their patients? How do we answer that question? I mean, what are some of the things that go into consideration?
Well, it's a settled principle of law that we can do it. And the United States Supreme Court ruled in a Massachusetts case around 1911. So we know that we can do it. And for state public health officials, it really is to what degree we want to make people do something that they really would benefit from doing themselves, but we want them to do it for the right reason. We don't want them to do it because we're making them do it. And it's a delicate balance. You know, a really good example in a non-public health care is the right of eminent domain. You know, as populations expand, we need a better transportation system. Here in New York is a really good example. You've got Saratoga County that's just north of the Mohawk River. Do we need another bridge? You know, if the growth really takes off, we're going to probably need not only one, but maybe two more bridges, or we're going to have to expand. If we want to build a bridge, we're probably going to have to take someone's land, land that's been in someone's family for generations, and we don't really want to do that.
Sure.
But then again, we're entitled as a community, you know, to take someone's private property for public use if it's in the community's best interest. And I think that's exactly what we're talking about with the flu vaccine. You know, we're taking someone's liberty, you know, and we'd rather not do that, but we're doing it for the benefit of everyone.
So I think sometimes the question then becomes who's the one who makes the decision about what's best for the community, and that's really where a lot of these things start to get complicated. And one of the things that you had talked about was people's right to privacy, and how does that factor in?
Well, the reason the right to privacy is so important in America is because it's a fundamental right. In other words, we can't take little bits of privacy away from individuals without a very dramatic compelling state reason,
Sure.
you know, to do so. And in fact, that's really what we're talking about today. The flu vaccine is taking the individual's rights, and these next couple of cases that we're going to be discussing is the state stopping us from doing something that we would really like to do because we think it's in our best interest, whereas the state or those stakeholders, the representatives that make the laws, think that it's probably better that individuals not have that liberty. So it really does work both ways.
Yeah.
And again, one of the goals of public health is to involve all the stakeholders in the decision, and it's a public debate, which is why it oftentimes takes so long to resolve some of these dilemmas because we do it incrementally.
And trying to take into consideration all of the different voices that are at the table regarding the decisions.
Yes.
So the next issue that you were going to talk about is the emergency contraception, the over-the-counter availability. So let's talk a bit about that, and start off just talking about what do we know about emergency contraception?
Well, Dr. Usby, a Canadian physician in the early 1970s, first suggested the notion that women should have emergency contraceptives available. They have unprotected sex, and many times, even when people take birth control pills conscientiously, that pregnancy can result from that.
Sure.
So if someone misses one or if they miss two pills, that really does interfere with the medicine to work effectively. So Dr. Usby created the Usby method in the early 1970s and suggested that women have an extra pack of birth control pills available. So if they have unprotected sex, and by protected I'm talking about sex that might cause pregnancy. If they have unprotected sex, they could take all the pills in that package, 28 if you have a package of 28. You could take all the pills at one time in a concentrated dose and really decrease the likelihood that you're going to have an unwanted pregnancy.
Sure.
And in fact, public health departments around the country And student centers, student health centers in universities have known about this. And we've got hundreds of thousands of women who in the 35 years prior to developing Plan B or Plan B-like products use that use-B method, to prevent unwanted pregnancies. So emergency contraceptives that we have today is usually 1 or 2 pills.
Okay.
All right, but they are the equivalent of an entire pack of birth control pills. Now that's not exactly, but it's a good approximation.
So rather than having to take that entire packet to prevent pregnancy, which is what has been done historically, now there's the availability where you just have to take 1 or 2 pills to achieve essentially the same outcome?
That's correct. And initially it was available by prescription.
Okay.
And America, the United States, was one of only 1 or 2 nations around the country that didn't make emergency contraceptives available to all women. So it was really, the issue was not the availability of the product, it's whether or not it should be prescription versus non-prescription. Now, you mentioned earlier about historical context.
Mm-hmm.
And this is a really great case to illustrate that, because the right to privacy that we have in the United States, articulated really the way it has been, was a consequence of a 1965 case called Griswold versus Connecticut.
Okay.
All right, and in Connecticut, I mean, law professors would argue with me the way I'm describing this case, but it was really about whether or not doctors in Connecticut could tell married couples how to avoid getting pregnant, and even have the conversation with them about unwanted pregnancies and the tools that are available. I told you that I was a pharmacist. My very first job, I was a soda jerk in the small town drugstore. Condoms were not available, readily available. If you wanted to buy condoms, they were behind the prescription counter, and you had to ask someone for them. I mean, can you imagine, teenagers today thinking of the world, in that context? But all of this has really evolved because of our right to privacy.
Sure.
All right. So with prescription medicines, the emergency contraceptives are less available than they would be if they were available OTC.
Sure.
So the argument with emergency contraceptives today is whether or not they should be available, to whom should they be available, how widely should they be available, how much information do people need before they buy them. And we know from the use-B method that the products are completely safe and effective. Mm-hmm. And we know from their availability from countries around the world that harm hasn't really resulted. But values in America, the family, the family unit needs to be protected. One of the ways that we protect the family unit is we reduce the likelihood of promiscuity, between people that are not married. Okay, does making condoms or does making emergency contraceptives available to those people reduce the likelihood that we're going to really protect the family? Now, the same argument, of course, was made with the availability of HPV vaccine. We were thinking that if we had HPV vaccine and people would suddenly have more unprotected sex than they would otherwise.
So the question really is, it's almost different, as you said earlier, than the original. When we were looking at the flu vaccine, it was, do we force someone to take something to protect the community? And with this, we're looking at, okay, we have this drug available from other countries, and from history, we can see that it's safe and effective. But do we restrict access to it because of a belief that we're going to somehow negatively impact society's health?
That's it. That's it. For a teacher, that's exactly what you want to hear from someone that you're having conversation with. You've made the point.
So what has the court said on this issue?
Well, it's evolving.
Sure.
And I'm thinking that probably emergency contraceptive is going to be available to everybody pretty soon, and that's the way it's directed. After, I think from the slides we've got the dates and people can read the newspaper articles themselves, a lot's happened since then. In the Obama administration, has been breaking, I mean, it's been changing its position based on what the court said. But if you look at, I mean, the very last thing is the FDA was approving something for persons 15 years and older. Well, you know, I mean, we mentioned earlier on one of the slides that I was the public health officer in Tennessee for a while. That was in Moore County, Tennessee.
Okay.
And at the time, we had one 12-year-old who was pregnant almost every month. We had one of the worst teenage pregnancy rates of any county in Tennessee, and Tennessee has 95 counties. It's just unfortunate, you know, that that children are having children, or I think of that, and I see that as just as much a threat to the security of the family and the family unit as I do many of these other issues.
So again, another really complex issue that we have to weigh what's going to benefit the community, and there might be various opinions based on the stakeholders, but ultimately there's going to be legislation that sort of settles.
Again, it's and we in America, you know, the way that we get along with one another is that we believe in the rule of law, and we respect the law. We'd like for people to make decisions based on what they think is best.
But sometimes we have to look out for others.
And we absolutely, and we codify it.
So let's talk, we've got another issue to discuss, and that's the use of medical marijuana. So let's talk a little bit about that. I know it's currently been sort of in the forefront of the news, so just start off giving us some history or some background on that issue.
Well, marijuana has been available as a drug for centuries. It started there is a book that I intended to recommend to people that's from the 1970s when the drug abuse war, you know, was being raged so widely in America, even more than it is today. And it was written by Consumer Reports, and it's got a really great history of medical marijuana. And I think we've got my textbook referenced, so much of that history is kind of summarized there as well. Queen Victoria, you know, took marijuana, you know, as a drug when she was delivering her children. You know, it was a drug that was available to her. It was a tincture. It was really taking the marijuana leaf, macerating it, pouring alcohol through it, and then kind of collecting the tincture, you know, that resulted. But it was a formulary product. In fact, it was available. Physicians, you know, under the Marijuana Tax Act here in the United States in the early 1930s, you had a special license, but you could prescribe it. You know, so it was available. And I don't want, and to be honest, marijuana as a drug is safer than alcohol, because someone could drink alcohol to toxic levels and die as a consequence of the alcohol. You know, according to Consumer Reports Journal, no one has died from marijuana intoxication. So again, some people would get really upset with me for saying things like that, but it's that values. I'm giving you scientific information.
Sure.
You know, now that's not to say that it's not dangerous when you smoke marijuana, because some reports are that it causes cancer, just like cigarette smoking, you know, would cause cancer. But marijuana is a very safe and effective drug for some purposes. Glaucoma, for people who have high intraocular pressure, marijuana reduces the intraocular pressure. So if someone could take marijuana, you know, and reduce the need for other medicines when they have glaucoma and reduce the likelihood of blindness, why would we not want them, you know, to have that drug available?
So what are the issues? What comes up when we're, you know, if you can present scientific evidence that says this can reduce this chronic condition or this pain for this person, and we can see that there's been a historical use of marijuana, why has it become an ethical issue? What's really the core?
Federal regulators in the 1920s and 1930s issued report after report after report that indicated that if you start smoking marijuana, that you probably are going to start using harder drugs as a consequence of that. California, which is really kind of curious, California in the 1913 or so was the first state to criminalize marijuana. They were also the first state to authorize medical marijuana. So does marijuana lead to harder drug use? You'll find some reports that say yes and some reports that say no. You've got the state of Colorado who only recently decided to regulate marijuana the same way that they regulate alcohol. And again, lawyers would argue with the way that I'm making that claim, but yet that appears the way that it's going to be in the future. So in California, in the 1990s, a group of people were able to get a bill, proposal, a proposition on the ballot that would allow the citizens of Arizona to decide whether or not to make marijuana available for medical purposes. And it was called the Compassionate Use Act. And only last month, or wasn't it, that Vermont passed a very similar statute. And I'm sorry, I think Vermont had done it earlier. I don't want to confuse the physician-assisted suicide statute. I'm getting those mixed up now. But other states have done so too, and I think there's been about 20 plus the District of Columbia that has decided to make marijuana available to patients if they meet certain medical criteria, which in effect means a physician is supposed to write it. But again, does marijuana lead to harder drugs? The United States Supreme Court decided this in a case, the Reich case, Gonzalez versus Reich. Very, very good case. It's really about states' rights versus federal rights. I would recommend that for people that are non-lawyers to really read that. It's an excellent opinion. Or if they read the New York Times, because what swayed the justices, and Justice Stevens wrote the majority opinion, what swayed the justice was the ability to control it. I think that just as soon as marijuana can be made available in a standardized dose. Marijuana is lipophilic. It's very, very hard to extract the drug itself from the plant. I think once science figures out exactly how to deliver a certain milligram dose, and then determine that's the dose that would be effective for glaucoma or anything else, I predict that marijuana is going to be available, by prescription.
Sure, and that it seems like very similar, the ethical issues that we would consider are very similar to what we were looking at with the emergency contraception in terms of should we allow people to have access, and there's the debate on one side about is this beneficial to the target population versus could it potentially harm the community?
How much harm to the community are we willing to risk?
Okay. So let's, in the interest of, we've got a few questions from the audience. I want to make sure we have time to get to them. So let's talk about the physician-assisted suicide, because that's the last issue we have before we take some questions. So what is the issue with physician-assisted suicide?
Well, I think, and this is the one that I remembered earlier, this is May 20th, Governor Shumlin, in Vermont, signed the Death with Dignity Act. And if you look at the statute, it's very, very similar to the Oregon Death with Dignity Act. So there are 4 states in the union now, Oregon, Washington State, Montana by court decision, and then Vermont. And Vermont is the first time that the legislature, passed the statute that was really signed by the governor. In both Oregon and in Washington, it was by public referendum, just like the Compassionate Use Act. That's one of the really nice things about the western states, primarily the western states. For issues that are very, very difficult for the legislature, they can propose to the public, by proposition. And those statutes were enacted by public referendum. In Montana, it was a judicial decision, and it was based on First Amendment rights, individual liberty. Should the government interfere with someone's decision, to take their own life if they have a terminal illness and they're suffering, and they've determined that there's some things worse than dying, in fact, living is worse than dying. So in Vermont, they have the physician-assisted suicide statute now, Death with Dignity. It's a debate that's been going on in America and around the world. I think in the few slides, this is really a great conversational topic for a seminar, because if you look at murder, mercy killing, which is euthanasia, suicide, physician-mediated death, just looking at those definitions, and understanding the differences between them. But because of technology that we have in America today, I love this quote, and I think it came from McGuire. Death has lost its medical and moral simplicity. It's no longer a moment, but a process that can be lengthened or shortened. And the classic cases that we think about this are the ones that went to the courts, like Karen Ann Quinlan, who was surviving on a ventilator. Nancy Beth Cruzan, who was living because of artificial feeding. And then the Terry Schiavo case, which was the argument between the spouse and the parents, that was in the courts, for a dozen years. And she lived in a persistent vegetative state 15 years after she collapsed at home. The other articles that I have there from the medical literature, It's Over Debbie is a New England Journal, a Journal of American Medical Association article. Janet Adkins was Dr. Kevorkian's first case, and she had just been diagnosed with Alzheimer's disease. I think the case after that was the one from New York, Diane, involving Dr. Timothy Quill of Rochester. And then you have the Oregon ballot measure that was enacted in 1994. It was in the courts for 3 years after that. One of the nice things that's come from the Oregon is every single year they've been publishing data about how the law has worked and how many patients have availed themselves of the opportunity to get a lethal prescription, from a physician, how many patients have died as a consequence of taking that medicine versus the disease process itself. But just briefly, it's patients that are terminally ill, that have decision-making capacity, that go to their doctor and tell the doctor that I would really like to have a lethal dose of a medicine. It's not that I'm going to take it, but I would like to have it available. So if my suffering becomes unbearable, that would be a possible option for me. The doctor can't write the prescription immediately. They have to wait a period of 14 days. If the physician doesn't feel that the patient has decision-making capacity, there's got to be verification of that. Then on the 15th day, after the lapse of some sort of waiting period, the physician can write the medicine, the pharmacist can fill the medicine, and the patient would have it available. And the patient, him or herself, has to take the medicine. So it is a suicide. It's not, if someone else did it, it would be murder. But
this is sort of allowing the individual the choice or the right to make a choice over their own health.
Right. And those are the safeguards. And it's administered by the Department of Public Health, or I think they call it Division of Health Services, in the state of Oregon, and they're responsible for collecting the data.
So certainly, you've presented us with a lot to think about, a lot of very complex issues that, depending on what information you have available and the context, there's really a lot to consider when making these decisions. Now we've got some questions, but just as a last question for you, I know additional resources, if people want to learn more about what we've talked about today, what would you recommend?
Well, the reason I selected these cases is because I have a textbook for pharmacy students, medical students, called Drugs, Ethics, and Quality of Life. So 3 of these, except for the H1N1 situation, are discussed. And again, it's presented in a seminar. There's any number of good texts. Let me recommend one other written by Greg Pence, who's a philosopher at the University of Alabama. It's called Classic Cases in Medical Ethics. And I really think it describes very well the principles, the values, the tensions. The very end talks about technology itself and the availability of drugs and allocation of resources. Because I think in the future, probably the strongest challenge we're going to have is how much money are we going to have? How are we going to spend it? How are we going to allocate those resources? And that's
a whole other...
It is, but it's a public health issue.
Absolutely.
Because it's an allocation of public monies.
So let me ask you, we've got a question from Dave from New York, and he wanted to know, when local public health is faced with choices such as who gets the limited vaccine, what is the ethical principle that can help with those decisions? That really ties right in with what you were just saying.
It's a great question.
And I just want to, we only have a few minutes left before the end of the show, so if you can try to summarize such a big question into...
This is why it's so important for public health officials to think about these issues and to plan for them.
Sure.
Because there is going to come a time when we're going to have to allocate scarce resources. And if you look back at those principles that we discussed earlier, there's any number of ways that we can resolve this. And there's always going to be somebody that's unhappy with the way that we do it. So we need to have, we need to have a process that's open, transparent. It's based on evidence that we have available to it, the best scientific evidence that we have, and then the public, to the degree that the public can, needs to resolve the dilemma.
That's, again, it's such a complex issue, and that seems to be such a straightforward answer that, of course, is going to get complicated as the individual situations occur. But I think that's a great way to summarize not only the answer to that question, but sort of everything we've talked about today, and emphasize the importance of planning for these things before they become a sort of imminent crisis, if you will. So,
which is, again, one of the rationales for having an informed public and a public health department that is involved with providing, better care, for patients.
Well, thank you so much for all of the information that you've covered today. I think we've really covered quite a wealth and an abundance of information on some pretty deep and multifaceted subjects. So thank you so much for being with us today and sharing your expertise.
Thank you. Thank you for having me.
And thank you for joining us today. Please remember to fill out your evaluations online. Your feedback is always helpful to the development of our programs, and continuing education credits are available. To obtain nurse continuing education hours, CME and CHES credits, learners must visit www.phlive.com and fill out the evaluation and post-test for today's offering. Additional information on upcoming broadcasts and relevant public health topics can also be found on our Facebook page. Don't forget to like us on Facebook to stay up to date. Also, as a reminder, you can download the companion guide to this broadcast on our website, phlive.org. The companion guide will provide you with learning activities to help further your knowledge and understanding of topics covered in today's program. This webcast will be available at our website within 2 weeks on demand, and DVDs of any of our past broadcasts can be ordered from our website as well. Please join us for our next broadcast on July 18th as we look at the impacts of climate change on public health. I'm Rachel Breidster. Thank you so much for joining us on Public Health Live.